next introduce Dr. Nimrita. She will be talking about choroidal detachment following GAT surgery in PACGI.
Good morning, everyone. My topic for case presentation. My topic for
Slides.
my topic. Good morning, everyone. My topic for case presentation is a rare case of choroidal detachment following GAT and primary annular closure glaucoma. A 54-year-old male patient came with a gradual progressive decrease in vision in both eyes, right eye greater than left eye, since 4 months with status post peripheral patent PI and was on 2 anti-glaucoma medications, Alphagen and Timolol. On anterior segment examination, IOP by GAT in right eye was 22 mm Hg and left eye 18 mm Hg. Visual acuity in right eye was 660 improving to 636 and in left eye 618 improving to 69 with patent LPI in both the eyes, and right eye had nucleus sclerosis grade 2 with posterior subcapsular cataract and left eye nucleus sclerosis grade 1 to 2. On undilated gonioscopy, both eyes showed grade 0 and which open on indentation to PTM 2B except in right eye which had passed nasally. On dilated fundus examination, right eye showed 0.9 inferior rim notch with superior rim thinning and left eye pointed superior rim thinning. On visual field examination, 24-2 and 10-2 for right eye showed advanced visual field defect. After 1 month, the patient presented with high intraocular pressure in both the eyes, so PG analog was started for both the eyes. So after 2-week follow-up, IOP was still refractory. Right eye had more IOP than left eye, so surgical management in the form of combined GAT with phacoemulsification was planned. These are the steps. After phacoemulsification, the pyoprolene suture was blunted, and then GSL was performed with cyclodialysis spatula. Nasal goniotomy incision was done. Then the blunted tip was passed with Schlem's canal and retrieved from the other side after completing 360 degree. Post-operatively, a tapering dose of Dexorin S was started. Pilo was given BD for 2 months and Nepalac OD for 2 months. On 2-week follow-up, the visual acuity was 636 improving to 624 with a low IOP of 5 mmHg, and on dilated fundus examination, it showed peripheral 360 CD which was confirmed by B-scan. ASOCT was done to rule out any cyclodialysis cleft which was not there. So, conservative management was started, tapering dose of steroids was continued, Pilo was stopped, and cyclophagic in the form of atropine BD was started for 2 weeks with systemic oral steroids. On a 3-week follow-up, visual acuity improved from 612 to 69 and IOP also increased up to 14 mmHg, and dilated fundus examination showed complete resolution of 360 degree CD which was confirmed by B-scan. Coming to discussion, CD has been recently is seen as an early complication post trabeculectomy in 7.9 to 18.8% of the cases. Risk factors include old age, a large difference between pre and post trabeculectomy IOPs, thicker corneas, and hypotony. Mix is now being explored in primary angle closure glaucoma and also in advanced angle closure advanced glaucoma, and has comparatively non-vision threatening post-operative complication. So the potential causes can be due to surgical trauma, acute hypotony or low IOP, and vitreous disturbance. So this was a study reported by Agachi et al. In which GAT was done in 33 eyes of open angle glaucoma, and ciliochoroidal detachment was seen in 14 eyes, which was seen by the ASOCT. Another study by Sharkawi et al. In which GAT was done in primary angle closure glaucoma of 103 eyes and only 1 patient showed low IOP. Another study by Yan et al. In which GAT was performed in open angle glaucomas and only 3 cases showed supraciliary effusion and ciliochoroidal detachment, which was resolved after 1 month after surgery. So why this case? Till now, very few literature has reported choroidal detachment after combined phaco-GAT in primary angle closure glaucoma. And to conclude, choroidal detachment following GAT in PACG is a rare complication that can be managed conservatively, and it does not affect the long-term outcome of surgery. These are my references. Thank you.
Thank you. Can we take the
Yeah. Hi, Dr. Nimrita. So I have a question for you. So you said that there was no cyclodialysis.
Yeah.
But how do you test for cyclodialysis? What is an instrument that you use to see for cyclodialysis clefts?
No, we did the ASOCT and
So ASOCT does not tell us about cyclodialysis at all. Swept source ASOCT that the case here it may or may not show you, but the ASOCT that you showed, it did not show CLD bodies at all. So we don't see you're not ever sure. So did you do gonioscopy in your case?
yes, we did gonioscopy. On gonioscopy, it was not seen the clefts, ma'am.
So
And
why
you
is
know,
it you showed that it is very rare to have hypotony after GAT? There are 1 or 2 cases and those 2 had cyclodialysis clefts. So why do you think it is rare to see hypotony following MIGS?
Ma'am, because there can be surgical trauma.
No, why is it rare? Why it doesn't happen? Like in trabeculectomy you showed it's very common. But why after MIGS it is so uncommon that you have to have an etiology for it? Why is it uncommon?
When are you targeting? What are you targeting with MIGS? Any MIGS? GAT?
Trabecular, the French canal, the trabecular.
So
Yeah.
ROP cannot be lower than your episkeletal venous pressure ever. So you have to have an etiology. So you have to have a cyclodialysis cleft. That's my take on it. Without it, you can't have choroidal, and it healed on its own. You gave steroids, it healed on its own. So, but you missed it. So that's okay. So very few cases require surgical treatment if you have cyclodialysis cleft. But what is the etiology of cyclodialysis cleft after GAT?
But ma'am, the pre-op IOP was high only.
Yeah.
The mixed surgery is not done if the IOP is lower than episcleral venous pressure. But in our case, the IOP was very high only. So that cannot be considered as an risk factor to cause cyclodialysis.
No. What madam is saying is the whole pathophysiology of how the mix works is through you will break the Schlemm's canal and you're using the trabecular meshwork the outflow pathways.
Yes.
So outflow pathways are not impacted. So it cannot go beyond the visceral pressure. Whereas in trab, you're making a bypass. You are touching the ciliary body and therefore you have a high chance of cyclodialysis or ciliary body shock. So the reason that after GAT or any other mix, the hypotony is so low is because it cannot go below the visceral pressure. That's what ma'am is trying to tell you. And that's what she's saying, that probably you've missed the cyclodialysis cleft and ASOCT is not the correct tool. Gonioscopy or if possible UBM
UBM can
would
be
have
done
taken
after
it out.
that.
Any take on that?
I have another small question for you.
Yeah.
Yeah. So, what was the intraocular pressure immediate post-op? The next day, first day post-op?
Ma'am, the first day IOP was 10 only, but on 2-week follow-up it went to 5 mmHg.
It went down.
Yes, ma'am. Yes, ma'am.
Yeah, I think definitely to look for a cause whenever you have a hypotony after mix, and UBM would be the best tool if you're not able to see it through gonioscopy. I understand doing UBM is also a challenge when the pressure is low, but we definitely have to look for a cause unlike trap.
And do we need to do a UBM if the pressure is low and it's resolving on its own? Because it is a challenge and you just kind of wait, you give time to trial. So